Good morning, everybody. My name is Chris Vincent, and I'm actually clinical director at FLX. It's really my pleasure to welcome all of you in this education program. The education program where FLX is engaged in PCR valves of 2020. The main team is Meet the Master, Meet the Expert in Digital Heart. And this morning we have a session on left atrial appendage and learning predictive value of virtual implants in left appendage closure with the WATCHMAN FLX. It's really a pleasure for us because so far we were able in FLX to simulate the WATCHMAN, and as of end of this year we will also include in our workflow the WATCHMAN FLX. It's a big honor to have Dr. Sandeep Panikker, who will be the speaker in that session. Is for the University Hospital Coventry and Warwickshire in the UK. So it will be a 30 minutes a session, including interactivity. There are multiple ways to create some interactivity in these sessions. The number one is the quick polls. So you will see at least 2 quick polls in these sessions where Sandeep, Dr. Panikker, will ask you a few questions. So please react on that. And then we will evaluate, analyze the answer on that. And also there is a chat line on the bottom of your screen. You can click on the chat and you can ask any question you want. And I will be the coordinator to ask those questions to Dr. Panikker during the session. So please ask questions. Creativity and interactivity is extremely essential in such an education session. So by saying that, I also would like to show you the learning objective of the session. What can you expect out of these sessions? So at the end of the session, as you can see in the bottom of the screen, you should be able to evaluate different LAAo morphologies and what are potential challenges in those morphologies by making preoperative decisions. You can also understand the role of patient-specific virtual implants in those different morphologies. You can also explore together with Dr. Panikker the different functionalities that we do have in the FLX Heart Guide preoperative planning tool. So what can you look at to help you to guide your decision mechanism, and then to participate, last but not least, in the case-based discussion that highlight the clinical value of advanced preoperative planning. I wish you all a nice PCR valves this year, and certainly a nice session. So thank you, Dr. Panikker. Now I leave you the floor to you. Thank you.
Thank you very much, Chris. Just share my screen. So thank you very much, and welcome to today's session, which will be looking at virtual implants in left atrial appendage closure, with particular focus on the WATCHMAN FLX. So I'd just like to take you through a couple of case presentations, just to give you a real feel of the types of cases that we've done and really where the modeling has helped us. So the first case is a 79-year-old female, quite a typical patient with hypertension, permanent AF. She's had a previous stroke and her LV function is good. So she's been on long-term warfarin with pretty stable INR control. And unfortunately, she suffered a spontaneous intracranial hemorrhage, so a hemorrhagic stroke, whilst on warfarin, though with a therapeutic INR of 2.4 just prior to the stroke. So the warfarin was stopped. The poor lady spent a long time in rehab as she had a dense left hemiplegia. She then, with very intense physiotherapy, recovered and was walking and was able to do her gardening. So at this stage, I reviewed her as she was obviously not anticoagulated, though had a very high CHA2DS2-VASc score, indicating that her risk of ongoing thromboembolic events, having already had one, was very high. Unfortunately, of course, with that, she had a high HAS-BLED score, and therefore anticoagulation in the medium to long term would not be a possibility. The second case is a younger person, so he's a 59-year-old male. He also has hypertension. He has symptomatic paroxysmal AF initially, mild to moderate coronary artery disease, and also good LV function. He had a spontaneous subdural hemorrhage on dabigatran, so that means with no trauma preceding it. And this was managed conservatively. So it was bilateral, though it was managed conservatively without any surgical intervention, as he was neurologically fairly intact. So the DOAC was appropriately stopped, and it was commented at that stage that there would be a high risk of rebleeding if we were to reconsider starting it. He then developed persistent atrial fibrillation a few months later, and unfortunately a month after that, off the DOAC, had a right middle cerebral artery territory infarct, which led to a left hemiplegia, though that was fortunately transient, and he made a full recovery. So dabigatran was restarted, obviously cautiously, after discussion with the neurosurgical team, though of course there would be a high risk of recurrent subdural hemorrhage with long-term treatment with this. So he had a CHA2DS2-VASc score of 4 and Hasbro score of 3. So both patients were at high risk of further thromboembolic events, but unfortunately also at high risk of further bleeding events. So the treatment objective was clear. I was planning to implant an appendage closure device to both minimize their thromboembolic risk off any anticoagulant, and also therefore reduce their risk of recurrent intracerebral bleeding, the one type of bleeding that most of us are fearful of. So these two patients were done during the pandemic, and with the scheduling issues that we all would have faced, I thought it would be important to plan as much as I could. So I performed a CT of their left atrium and left atrial appendage, and this was predominantly to ensure that they had no thrombus. So I wanted to minimize the risk of them being cancelled on the day if we found that they had appendage thrombus. So that was performed to help rule that out. But importantly also to ensure that the left atrial appendage was neither too small nor too large with the device sizes that we had available to close percutaneously. So I'm going to move on to our first quick poll. Just wanted to gauge from the audience, how comfortable are you in making a sizing or position decision for appendage closure cases based on your standard preoperative data? So what you would use as a standard case? If you could submit your answers, thank you.
The people are voting.
Just going to wait a short while just to get everyone's votes in, and then we can move forward. How are we doing, Chris? Great. Okay. So I can see ahead of time that approximately 2/3 of people are already comfortable with the standard preoperative data, and I would expect that to be. This is an experienced audience, and I'm sure a lot of people have been doing this for some time. But at least 1/3 of people are not comfortable with that, and just over 1/3 actually. And I think that's important, and we'll talk about that. So I'll just close this poll. So preoperative planning for complex anatomy, and we know the appendage is a complex anatomy, is challenging. And that's because there's no standardized way to do this. It is very much operator dependent. So the more experience you have, hopefully that will then lend itself to better sizing decisions. But it's very much a nuance. And it can be challenging to predict for difficult anatomies just how the device will behave within that. So I've seen that in the past. We've got appendages which look like they're very closable, and then you try and put a device in there, and it just does not behave the way you'd predict it to be. And that's because of the behavior of the mechanical tissue interaction. Now, most of the currently available software only provides you information of putting a device which is undeformed over the top of your current 3D modeling. And that means that you don't really get an understanding of how it's going to sit within that. So FEOPS offers a different solution. So it's a standardized AI-based software solution which allows you to then predict the anatomy, and then also, importantly, predict how the device and the anatomy will interact with each other. So you can see here, Now, this device is not how it would look when it is coming out of the packet, but in fact is deformed appropriately according to the size of the appendage. So the first part of the FLX tool is to create a 3D rendering of the appendage based on the preoperative CT scan. And within that, the mechanical behavior of different tissues is incorporated. And then added to that, the 3D model of the appendage closure device in different conformations is then placed within the model, and the mechanical behavior of the device is taken into account. And that then leads us to the prediction of how both the mechanics of the device and the tissue of the appendage will interact with each other. And you can see here that there's very much different deformities of the device depending on where it sits within the appendage, and that's very valuable. So in 2019, in the Journal of Cardiovascular CT, Barvo et al. Reported a validation of this of the FLX model. Of course, there's been a lot more since then. So this was using 30 patients with pre and post appendage closure CT scans, equally distributed between the Amulet and the WATCHMAN, the 2.5, not the FLX device. And what the study was designed to do was to match the implanted device position with what the simulation predicted. And what you can see here is that there was a very high correlation between what was observed after device implantation on the CT and then what the software predicted with the pre-op CT. Of course, things have gone on a lot more, so this is an AI-based simulation, and therefore the more information you feed into it, the better. So at the moment, I think there's nearly 300 cases that have been put into the model, and certainly more with the WATCHMAN FLX. It's about 25, and that will increase with time. So let's move on to the first case. This is the lady that we talked about. So as you can see from this appendage angiogram, there are two dominant lobes. So there's quite a long run-in. There's a dominant lobe distally, so that's the anterosuperior lobe, and then the infraposterior lobe. So the infraposterior lobe in this case was larger. Now we tend to, with WATCHMAN devices, selectively intubate the anterior superior because that tends to give us the best coaxial position for the delivery device. But in this position, actually, it felt that the most coaxial position was gained from going into the infraposterior lobe. So this was a relatively reasonable anatomy, but there were some nuances picked up, and actually Heart Guide really helped with this. But I have to be upfront here that because, as Chris has alluded to at the start of the presentation, the WATCHMAN FLX device is a relatively new device, and that means that FLX had to feed this information into the system. So it is in the final stages of development, modeling of the WATCHMAN FLX. The WATCHMAN 2.5 has been modeled for some time now, but the WATCHMAN FLX, the full commercial release of modeling within FLX will be available within the next few weeks in December. So this is really done after the case, but it's actually really interesting because what I ended up putting in was what the device, what the model helped to predict. So I'll take you through that now. So as it's not commercially available, this is just a video of what will be available online. Otherwise, I would have switched to an online format. So this is the video. And what's really good here is that you have a 3D model and you can spin it around in whichever position you want. So we can spin it into any cranial, caudal, LAAo, LAAo view. And obviously the working view when we implant will be generally in an LAAo caudal view. What's laid on here is the position at which most of the osteal measurements are made, and then everything is done relative to that in terms of positioning of the device. You can bring on the circumflex, make it opacified or make it disappear by making it transparent. And that's great because you can then predict where the how close your device will be lying to the circumflex, and then what you will predict to see on your TOE. So you can spin it around whichever position you want and looking at every different orientation. I think that's really good. And what you can see on this particular model, and I'll just take you through that, is that there was a large pouch here. So there's a pouch just sitting there, and that's quite sizable. And that's on the Coumadin ridge. So that was really helpful to know. And of course, we saw that during the case. So let me just run you through. Sorry, I just skipped forward there. So the first case was or the first modeled device was a 27mm WATCHMAN FLX. So just to tell you, what you can do is either based on what you think you may want, you can ask FLX to model the different device sizes, or you can just leave it blank and FLX will model the device sizes that are most appropriate for the size of the appendage. Of course, there'd be little point modeling a 20mm device in this case. What you also get, let me just pause that, is different values of the diameter of the appendage os at the level that was marked out by that blue circle. So there are different ways of analyzing this, and those of you who do CT will know that you can either do it by area-based diameter, perimeter-based diameter, and they're very predictably close to each other, or there are values that you can do by direct line of sight of minimum diameters and maximum diameters, and they all come out quite close to each other. So this is not a very elliptical, but indeed a very circular appendage, and that means that we can, you'll know that if you put a device in there, it will pretty much conform to the actual size of the appendage. So let's move on to the other parts of the tool. So you can see here there's a color map within the tool, and that shows you that the lighter the color, the less gaps there are. The darker the color towards the brick red, the more the gaps there are. Of course, on the device face, it faces the atrium, so there will be it will be red in color. But what you're looking for are confluent red areas that would then predict a gap that's flowing from the proximal face through to the distal face of the device. So what we wanted to do was to cover that little pouch, and what you can see here is that the 31mm device was actually quite well seated, so it did cover that pouch. There was a small gap here, so that was important that when we were implanting to try and really cover that and bolster it so that it would be wedged within that little area there, so it couldn't, so no flow could go across that. But there is a bit of a shoulder here, so that's the proximal position. And then we move to the distal position, which will be next. Just select that in a second. Oops, sorry, bear with me. Let me just skip through that. So the distal position will be coming up here. So the distal position is here, and what you can see is that that pouch is now uncovered. So this would not be an optimal position for me, but for other reasons, if there was no pouch there, it would be great. So for those of us who do implants, we know that covering the whole Coumadin ridge is not necessary because it's relatively smooth and thrombus does not tend to form there. But with such a sizable pouch, I thought it would be important to cover it. Now this is a 35mm implant, and as you can see here, it really does protrude a lot and doesn't really offer you any significant benefits to the 31mm device. So I'll just annotate on here where I felt the best position would be, and I thought it would be this one here. So we've got, what you get is then a report which shows you all four of the predicted device positions and then shows you what the mean shoulder diameter would be, so you can predict what kind of percentage compression there would be. And what I felt best would be the proximal position on here. And that seems to mirror what we ended up doing clinically. So I'll just move on to the next slide. So here's some TOE and simultaneous fluoroscopy of the case. I do apologize for the poor visualization on the fluoroscopy. There was a problem within our X-ray system on that day, so it was fairly low resolution on the day. But what you can see is that there was, in all the views, that the device actually very much predicted, this was a 31mm device, it very much predicted, or the model very much predicted where we eventually put this. So you can see it's well seated, it's well wedged within underneath that that little pouch, and there's no flow. So this lady had a very poor flow within the appendage, so we had to drop the Nyquist limit down to below 20, and there's no flow at all. So that's great, and that was obviously measured in multiple different views. And this is the final position where you can see that there is some protrusion, but it's certainly well compressed within this central waist here. And as those of you know who implant these devices, there are 2 rows of anchors which come below the 50% mark and then even below that too. So this is well well positioned there. Let me just clear that off. Okay. So moving on to the next screen. So the summary of this case is that this was done slightly differently. So we actually did the clinical implant, and then we moved on to the and then the model really helped me understand what it can offer, and then also it really did predict the appropriate device sizes. So you get a range of device implants, but you can choose from there what you feel is the most appropriate. And certainly the 31mm device in a relatively proximal position within the appendage, I felt was optimal, and that mirrored what we implanted clinically. It did identify the prominent pouch within the Coumadin ridge, and that was only really evident when we did the procedure, and it showed sufficient compression of a 31mm device. So moving on to the second case now. This was a very different case. This was the younger man, and as you can see here, we have one of the most difficult anatomies, and that's a retroflex, a retro-PA chicken wing, and it had a short, wide neck which then funneled in. So this would be the most difficult type to implant with the original WATCHMAN device, but the FLX offers you a shorter device, as the amulet is as well, that allows you to implant within that. So overall, this particular anatomy was challenging, and again, the modeling was done after it was implanted. Now, just to add on here, the HeartGuide solution does allow you, if you have a sufficiently good atrial angiogram with the contrast you inject within your CT, that if it's well highlighted within the CT, FLX can actually mark where the PFO, where you should do your transeptal puncture, and that's the best aligned view to get into the appendage. So you can see here, this is a very superior retroflex chicken wing with a wide os and a fairly short run-in. So this is one of the more challenging anatomies. So the model predicted that we would, with a 27mm and a 31mm devices, you'd get reasonably adequate closure. Anything smaller or larger would either be too proximally placed or would not close properly. And there were 3 positions in this instance modeled with the 27mm device. So we have either the proximal position or the distal position, which I felt were most optimal. The distal 2 position was almost too compressed within. And what I wanted to do was ensure that I would cover the funnel, opening wide funnel of the appendage without risking this rubbing against the distal appendage. Though, of course, as those of you who implant these will know, it's certainly much better design now that the distal ends are closed off, much like the amulet, and that means that you don't get the risk of the distal legs perforating the distal part of the appendage. So within this, I felt that, and there was one part that this is important here, that this patient had symptomatic atrial fibrillation. So we actually did an ablation on him very early on in the after he had restarted his dabigatran. And then after that, we implanted the device. And the reason why it was important was that I did not want to have too much of an overhang out of the appendage. So actually an amulet would not be suitable because of the large disc that closes the appendage. It would mean that it would interact with the left superior vein and the mitral valve. And if I had to go back in again, I would then not be able to do the ablation successfully. So I wanted a relatively distal position. And certainly you can see the 31mm device would only be suitable in the proximal position because it would then abut the appendage in a more distal position. And this obviously protrudes too much, and it would interact with any ablation that I would perform. So the proximal position, I'll just skip back to that. So the proximal position, so the distal position of this 27mm device, I felt was the most suitable. And there were no circumferential gaps around that. But of course, this was done after the implant. So the implant we have here, so we have the TOE images, and as you can see, it's well seated within the ostium of the appendage. That's the circumflex artery there. And this is quite an aggressive tug test here. And you can see that the device is well held within the appendage, and it covers the entire ostium. And also flow within the appendage is limited. So this is just a different view, and there's some shouldering here, but it's still not enough to interact with the mitral valve, or certainly not enough to interact with the ridge and the pulmonary vein. So I can still ablate around this area if needed. I'll show you back. And this is just an angiogram after device release, and you can see the device is not moved. So it's a very well seated device here. So this 3D simulation again predicted the 27mm device in a distal position within the appendage was the most appropriate, and it certainly mirrored what I felt clinically as well. And it showed that it would be sufficiently compressed in this distal position without, in this particular case, excess device protrusion. And that was important because of the need to do an ablation and potentially a further ablation for this patient. So moving on to the next quick poll. To what extent now does utilizing 3D simulations such as what is offered in the FEOPS Heart Guide facilitate your decision making in complex anatomies? So if you'd like to vote. So the three options are, this will not change my decision. The second is, this will confirm if my decision is correct. And the third that will significantly impact on my decision. So please vote. Okay, so the votes are in. So that's actually really good to see. So although 64% of the audience were comfortable with their decisions with standard preoperative planning, I'm glad to see that just over half of the audience, 57%, will, when they're using this, will help it to confirm that their decision is correct. And I think that's also valuable. And then nearly 40% will feel that this will impact on their decision. And actually, I think that's also valuable because, as you'll see in my conclusions, there's lots of benefits to be had from this simple process of simulating what you predict. So,
yeah. Sandeep, there are some questions coming out from the audience. I would like,
yes, of course,
your opinion about that. So one question is about the catheter you are using. Do you use an anterior true seal curve for this case, for the last case that you were presenting?
So actually, what was interesting, this was one of the first implants, WATCHMAN FLX implants within the UK, and they didn't have the anterior curve because it was stuck in Europe. So I normally would have, but in this position, I actually used the double curve and it was fine. And that was because, so remember with the original WATCHMAN, you really had to deep intubate the appendage and you had to work distal to proximally. But fortunately with the FLX, like with the amulet, you can work more proximally or at least within the mid part of the appendage. So I didn't have to do the deep intubation and manipulation that you would have to usually do with WATCHMAN 2.5. So the anterior sheath was absolutely fine, and it was a true seal, yes.
Thank you. Another question is it possible to predict the position of the implanted device in order to avoid the DRT into the follow-up?
Yes, I think so. So, of course, I haven't done enough of these with, so I've done over 300 appendage closure cases, so it's something like 325 now. But I haven't used FLX enough to then to predict, but what FLX certainly does do is allow you to predict where it's going to be. And as we've seen from previous our previous experience, the positioning is important. And particularly gaps. If you leave things uncovered, so proximal pouches within the superior inferior margin, if you leave gaps around the device, that's important. That will predict whether or not you're going to get DRT. And so, yes, I believe this tool can help you predict that.
Wonderful. There is another question: is that how can you be so sure that that you don't have any filling defect when using the CT 3D reconstruction?
Yes, so that's very important. And in fact, if you, it's not trying to plug my publication, but if you look at a publication with my name from the Journal of Cardiac CT, so JCCT, there is a flow guide for radiologists to use on how to use their CTs for all types of appendage closure devices. So that's the WATCHMAN, the Amulet, and also the LAAo. And what it tells you is that you must have a second pass in there, so a pseudothrombus can be ruled out. So your first pass, particularly, and we actually saw it with the first lady, she had very slow flow, and the velocities were around 0.2 meters per second, and that meant that the first pass did not fill the distal third of the appendage. And FLX actually did very well because, of course, they do use the first pass to model the 3D anatomy, because they have to have enough of a boundary between the Hansford units, between the contrast and the rest of the tissue, in order to then create the 3D model. So what that meant was that they were able to then figure out what the distal markers would be. But of course, pseudothrombus is visible on quite a few patients, particularly those with permanent AF. But you have to have a second pass there to make sure that there is no pseudothrombus. So the second pass is as good as looking at it on TE. I hope that helps answer the question.
Thank you, Sandeep. There is a last remark, which is not a question, but a good remark from our friends from Boston Scientific. The way we are spelling the flex in the presentation, we put the flex with an E in the middle, but we need to be correct, of course, for all the audience. The WATCHMAN flex, the flex is a FLX at the end, and that's the acronym of the company. So thank you for this remark. Just to be sure that I need my camera. Thank you. Okay, can you go to the last slide, please, Sandeep?
Yes.
Thank you.
Okay.
Okay, first of all, I really want to say a big thank you for you, Dr. Panikker, for this really interactive session. So we had a lot of people on the line, which was extremely positive, really nice, a lot of interaction, good questions. It's just a beginning, of course, as you mentioned, with the WATCHMAN flex. So we will be discovering a lot more, and just be sure that you stay connected in the PCR valves, because we have much more coming. You see, this is the education room of convention, and there is other sessions coming. If you go to the main page of the PCR valves, then you can see other sessions on that. I wish you a very splendid PCR valve this year. And again, thank you so much, Sandeep, for this very nice presentation. Talk to you soon. Bye-bye.
Thank you.